All right, so let's come out of the surgical area and let's move into the metastatic area. So, Peter, NCCN guidelines, you keep telling us they're getting more clear.
Yes.
You know, it seems that there's a lot of different potential options for frontline therapy. So what does NCCN tell us? And then outside of NCCN or within NCCN, what do you like as your first-line regimen?
And I think you bring up an important point. The NCCN guidelines have been criticized, not just in this disease, but in other diseases, of being sort of an inclusive guideline where multiple regimens are included, and we really don't give guidance as to which is the best regimen. And in fact, one of my colleagues at Dana-Farber recently presented the largest database of regimens given in the United States, and you can see that basically people are all over the place with different regimens, and it's sort of based on small single institution phase 2 studies that might have been done in that area. But ultimately, what we've been trying to do in the NCCN guidelines is to give more guidance. And really, when you poll the NCCN members, really everybody uses the FOLFOX regimen. So FOLFOX is really the de facto standard of care in the United States. And my colleague's data shows that with every 5-year period, FOLFOX has increased by another 10%. And although it's not given now by the majority of oncologists, it's I think at 40% up to 2010. So it's probably now in the majority, particularly now that the guidelines have changed. We've kept cisplatin and 5-FU, and the reason is that it still is, unfortunately, the regulatory standard in the United States as well as in East Asia and Europe. It's the only one that we seem to be able to agree upon. And there's good, well, not necessarily good, but there's phase 1, level 1 evidence for cisplatin and 5-FU. But none of us would ever be seen treating with cisplatin and 5-FU. Only when we're required to in these global registration trials do we put our patients on cisplatin and 5-FU. So the guidelines really have two. First of all, we recommend doublets because we feel that in the palliative setting, the addition of a third agent really leads to significant increased toxicity without a survival benefit. There are clearly subgroups of patients that would benefit from more aggressive therapy, particularly in the neoadjuvant setting. That's why FLOT is important to know about, or patients who are very symptomatic who need to have a response. But generally speaking, a doublet, 5-FU, leucovorin, oxaliplatin should do it for most patients. The guidelines do still include some of the lesser regimens, but really that's, and for instance, one of the important ones to know about is FOLFIRI. Some people can't tolerate platinum-based therapy, so irinotecan, the Europeans, the French did a very nice study comparing an ECF variant to FOLFIRI. The primary endpoint was time to progression. FOLFIRI was superior to the ECF variant. And the other parameters, overall survival, progression-free survival, were all the same between the two arms.
And Peter, just a quick side note, you were the author of one of the main studies that kicked off epirubicin. So are you not an epirubicin fan?
You know, so the short answer is no. But you know, I think that the problem with epirubicin is really that it became so ingrained with the MAGIC study and the REAL-2 study that many people used it. Was, you know, after all, it's a New England Journal of Medicine, so that must be the standard of care. So I think that we've come to understand that epirubicin probably adds very little to the treatment and does have significant toxicity. So we avoid this as much as we can. There are some interesting sort of 4th, 5th line regimens that incorporate this class of agent, and when I run out of standard treatments and they're not a candidate for a clinical trial, I sometimes sort of back up and use this, but that's really the only scenario.
Ouch. And if they're not a candidate for a clinical trial, I don't know if they're going to be a candidate for epirubicin, 6-line setting.
No, it's liposomal doxorubicin, right? It's a little bit better.
Now, Eric, is that different from what you guys recommend?
No, it's quite similar today. Epirubicin, the regimens came, of course, from Europe, but it was mainly done in the UK, Scandinavia, and the Netherlands. But now the last 2 years it has lost popularity, and I would even be a bit stronger than Peter, saying that there is no evidence of any activity at all for iberubicin. There is evidence for toxicity, but nobody has ever shown that there is evidence of this triplet with iberubicin. So the standard in first line is indeed FOLFOX in the HER2 negative patients, in the HER2 positive patients. Then it's fluoropyrimidine cisplatin is officially in the label with trastuzumab. In some countries, that's an indication where you have to use cisplatin because of the label. Some countries that can be replaced by FOLFOX plus trastuzumab in this situation. That's the standard. My guess is that around 10–15% of patients in first line across Europe get a triplet, but then not the original DCF regimen because so with docetaxel, cisplatin, 5-FU, as we described it, that was too toxic. Then people physicians give a modified regimen, FLOT, TOF, DOF. There are different variations with 5-FU, oxaliplatin, and docetaxel, 50 milligrams every 2 weeks instead of 75 every 3 weeks. This is done sometimes in younger patients with a high tumor burden who really want to hit, but that's only a small number of patients. And also in my practice, I give to most of the patients today FOLFOX as a first-line regimen with or without trastuzumab, depending on their HER2 status.
And I think very important to remind the audience, although now it's older data, is that again, breast cancer and gastric cancer are not the same. We saw those results from Jacob.
Yes, that's right. Trastuzumab has shown activity in gastric cancer in the HER2 positive patients. Pertuzumab plus trastuzumab led to a small benefit, but this was not significant. So the trial was negative of chemo doublet plus trastuzumab plus or minus pertuzumab. And then also the second line trial in gastric cancer, HER2 positive gastric cancer with TDM1 versus a taxane was also negative. So for different reasons, because of the differences in HER2, in the role of HER2 in gastric versus breast cancer, unfortunately the combination with pertuzumab and trastuzumab failed, and also TDM1 was not positive. On top of that, we have also in second line, you can ask a question, post-progression continuation with trastuzumab as is being done in breast cancer. Also here we see a difference. Until recently we didn't have any data. Recently, this meeting there's a presentation of a study which shows no benefit of the trastuzumab post-progression continuation, a Japanese study. So trastuzumab is there in first line for HER2 positive patients, not in second line. And another important and interesting aspect to come back on HER2 is that we see that, for instance, patients with a G-junction tumor, they're around 30% are HER2 positive. Patients with a real, more distal gastric cancer, positivity rate is lower. And patients with a signet cell tumor, there the chance of having a positive tumor is very, very low, only a few percent. So there are some interesting differences in this situation.
Very, very interesting. Now, Kohei, in Japan, I'm jealous because you have more things to play with. So in Japan, are there differences then in the treatment regimens you would use?
Yes, actually we revised the Japanese treatment guideline early this year. In the first treatment regimen, we classify into two. First is the most recommended regimen for fit patient, and the second is the alternative conditionally recommended regimen. For fit patient, we recommended any fluoropyrimidine or platinum agent. Any is okay for us. So we can also use FOLFOX because we have a long history of colorectal cancer treatment. So if patient has some dysphagia, so FOLFOX is a very good treatment. But otherwise, S1 plus oxaliplatin is the most commonly used regimen because our phase 3 trial showed a very similar outcome with S1 plus cisplatin. Hazard ratio in overall survival is 0.96, almost similar. So we prefer to use S1 plus oxaliplatin. Capox is also common in colorectal, but Soxy is more common in gastric cancer. In second line, maybe we can discuss later, but weekly paclitaxel and ramucirumab is the most recommended treatment, and nivolumab and irinotecan is also recommended in third line.
Very good, very good.